But I think he's here. Perfect. You're here, Ram? You're in?
Yeah. I mean, I got a bit worried because maybe I was too keen.
As long as you're here now, that's the main thing.
All right.
Great. So should we start? Perfect. Dear participants, I, Deep Narayan, would like to welcome you all in the UK-India Clinician Knowledge Exchange series. I'm delightful to share that it is the 4th week in a row for clinicians from both the countries to come together in this platform and share insights of COVID management. We have discussed key topics, starts from management of moderate to mild cases, reviewing of most prescribed prescriptions, and ICU optimization during pandemic. I'm sure many of our Indian clinicians have found it to be useful, and we are very thankful to all of our speakers, participants, and especially Dr. Chetan and Dr. Himangi for their wonderful support in this initiative. In the interest of time, let me quickly introduce you to one of our most dynamic physicians of our country, Dr. Chetan Dhamne, who is going to moderate today's session. Dr. Dhamne is the Associate Professor, Paediatric Oncology at Tata Memorial Hospital. Now, I would request Dr. Dhamne to share his views about the session. Over to you, Dr. Chetan.
Hey, thanks, Deep, for the generous introduction. So today we are going to focus on pediatrics, and we have eminent panelists from UK who are going to share their experience from how they have handled the pandemic so far. And I just hear that there is a rise in cases in London. So we would also like to learn from them how they are preparing for the third wave. I will not say much. I would let them say what they have to say, and then we will also have a question and answer session. So please keep your questions coming.
Thank you. Thank you, Dr. Chetan. Now I would like to welcome our guests from NHS one after another, and would like to start with Dr. Satish Rao. Dr. Satish is a consultant respiratory pediatrician and a Deputy Chief Medical Officer at Birmingham Women's and Childcare Service Hospital. He served on the Respiratory Committee for Special Training at Royal College of Pediatrics and Child Health. He's also the Senior Examiner for Clinical MRCP-CH, and his research interests are in the field of difficult asthma and sleep medicine. Now I would request Dr. Satish to share his views. Over to you, Dr. Satish.
Thank you, Deep, and thank you all. Good evening in India. It is indeed a great honor to be part of this initiative, which is bringing together clinicians from UK as well as from India, and this is such a perfect platform. COVID in pediatrics has been a specific challenge, although clinically we've had some challenges. We've been stretched by COVID, but children and youngsters have faced huge disruptions in every single sense because of COVID, whether it's education, their social development. And of course, the clinical bits of the COVID is becoming more and more relevant with the variant strain. So I think this topic is pertinent, and I look forward to a great session this evening. Thank you.
Thank you so much, Dr. Satish. Now I would like to introduce Professor Azeem Majeed. He's a professor of primary care and public health and head of Department of Primary Care and Public Health at Imperial College London. He's also chairman of the Imperial College Master of Public Health program. He has an international role in public health and primary care through his position as co-director of the World Health Organization Collaborating Center for Public Health Education and Training at Imperial College of London. I would request Professor Azeem Majeed to share his views about the session. Over to you, Dr. Majeed.
Thank you very much. It's a great privilege to be here today at this session. So globally, children account for a very large proportion of cases of COVID-19. It's important that clinicians do know how to diagnose and manage these patients, whether it's in the community or in hospital settings. It can be difficult because often the symptoms and signs are very similar to other viral infections. And so it's often hard to know who's got COVID and who's got some other viral infection instead. So I look forward very much to hearing today's session and learning more about COVID-19 in children and its management. Thank you very much.
Thank you so much, Professor Majeed. Our lead speaker of this session is Professor Ramanan. Professor Ramanan is a consultant pediatric rheumatologist at the Bristol Royal Hospital for Children. He is the joint lead for research division at the Bristol Royal Hospital for Children and professor of pediatric rheumatology at the University of Bristol. Professor Ramanan is a medical advisor for Olivia's Vision and the National Ankylosing Spondylitis Society. He is also chair of National Institute of Health Research Clinical Research Network, Child Arthritis Research, Pediatric Rheumatology Clinical Studies Group, and Associate Director for UK Experimental Arthritis Treatment Center for Children. With this, I would like to hand over the floor to Professor Ramanan. Over to you, Professor Ramanan, for your presentation.
Thank you very much for the kind introduction. Like everyone says, it's an absolute pleasure and privilege. If you could please enable share screen, then I will be able to share my screen. Thank you. I hope you can all see the presentation. Thank you very much. So it's a challenging topic, but also an interesting one about COVID in children. And I think I'm going to touch two aspects, which most of you as pediatricians are familiar with. What we see as primary COVID in adults, and then what really involves kids and leads to hospitalization and morbidity, and very, very rarely mortality, is the multisystem inflammatory syndrome, which is where the bulk of my talk is going to focus on. So let's look at what we understand of the immunopathology of COVID, or the SARS-CoV-2 virus, and why children for primary COVID are preferentially spared or seem to be mildly affected. So we know you need the ACE2 receptor in your nasal epithelia for the SARS-CoV-2 virus to bind, and then it localizes really and gives a pulmonary manifestation, which everyone's familiar with. We've learned a few things in the immunology over the last year, and we now know that those who get severe COVID in adults are the ones who have antibodies to type 1 interferon, which is a key innate immune system response and an adaptive immune system response to viral infections. And we know that some of those adults and some of the children with the inflammatory syndrome have a cascade of cytokines due to persistent inflammation for poorly understood reasons. And so we know that in the part of the virus-host interaction, the suppression of the interferon response during initial infection leads to severe COVID in adults and maybe in some of the adolescents, and that viral replication will trigger a cytokine cascade, which probably contributes to a lot of the damage. But the low prevalence of ACE2 receptors, particularly in children under 5 and less in children under 10, means for a large proportion of the children, primary COVID, that is the pulmonary COVID that you see, the infective COVID, is extremely rare event. And most children, when they get exposed to the SARS-CoV-2 virus, have a mild self-limiting illness. Now you're going to say, do you have any data? So here's the Ivig cohorts, clinical characteristics of children and young people. So this is very much a British cohort, and it's a prospective multi-center observational study. And we know that less than 1% of the patients in the first and the second wave were children with primary COVID. The bulk of the problems that the NHS faced with pediatrics was really the multi-system inflammatory syndrome, which was referred to as pediatric multi-system inflammatory syndrome temporally associated with COVID-19, or PIMS-TS. But for purposes of this talk, as it's globally known, I will call it multi-system inflammatory syndrome. And what I'm showing you here is that even in these self-limiting episodes, only a proportion have fever. Some of them may have what looks like an upper respiratory tract infection and may be indistinguishable from a lot of common cold. But we know this is SARS-CoV-2 because in the first wave with lockdown, as my colleagues, at least Dr. Satish will tell you, the children's hospitals actually in the first wave had very little inpatients because we didn't have the COVID problem we thought we'd have, and we weren't able to do some of the other outpatient activities we could do. So really, primary COVID is an uncommon problem in kids. And here's a 3 meta-analysis. What will you get? About 1 in 5 children will be completely asymptomatic after exposure to SARS-CoV-2. And about half of them will have low-grade fever, which will spontaneously remit in the vast majority. Cough is probably the most predominant symptom, along with rhinorrhea and what looks very much like a common cold. Myalgia might be seen in 1 in 5, as does sore throat. And then a host of other manifestations which are really minimal. And I'd like to draw your attention to abdominal pain, which is not a feature of primary COVID in kids. But the key problem that most of you as pediatricians, and I know most children's hospitals in India are getting about 2 to 3 cases of Missy every day for the last few weeks, is really how do you discriminate between who's had acute COVID, which is an infectious event, and Missy, which is really a post-infectious event. And the key presentation of Missy, which I'll come back to, is a fever with abdominal pain. There are loads of anecdotes here in UK, as well as increasingly in India, of these kids presenting with what looks like acute appendicitis and sometimes even having the appendix removed. So the presentation will look more like a toxic shock syndrome or an appendicitis or a bacterial sepsis, whereas acute COVID is more likely to mimic common respiratory tract infections, which with lockdown and absence of school should be less common now than it is usually. And dengue is a usual problem in this season, but again, I think I'm led to believe dengue this year is not as prevalent as in the previous years. And there are a host of differentials you have to consider. You might think of myocarditis, intussusception, and Kawasaki with Missy. We'll come back to that. And probably the non-infectious causes for acute COVID are a host of things, such as reactive airway disease, if they have respiratory difficulty, but they shouldn't have fever. So let's look at Missy, which is where pediatric populations are at greatest risk. This, when it presents, the median age is about 8. So this is usually the older child between 5 to 15. It's less common in children under 5. And they can present with warm shock. Certainly in the first wave, all around UK, we realized that some of these children were presenting with shock, probably aggressively fluid resuscitated. And some of the outcomes which were adverse weren't seen with the second wave. But a significant majority of these kids need admission to intensive care. About 1 in 3 may need ventilatory support, but 1 in 2 will need inotropic support or vasoactive support. Fortunately, if recognized early and treated appropriately, that should be an extremely rare event. So what does happen in Missy or multisystem inflammatory syndrome? We know the 2 arms of the immune system. You have the innate and the adaptive immune system, and we think there are probably mechanisms at play which involve a defect in the innate immune system, and you will have the cytokine storm. You probably have a complex interplay between the adaptive immune system and the innate immune system, which leads to this tissue damage and endothelial cell activation. And I'll come back to what that happens in terms of the bloods. So what is the case definition of Missy? You'll have a child who presents with persistent fever, who baseline bloods will show a high neutrophil count, an elevated CRP, a low lymphocyte count. These patients can present with single or multi-organ dysfunction and may fulfill some or all of the criteria for Kawasaki, but age would be against Kawasaki. Even in any setting, including when children are isolated, not going to school, things like bacterial sepsis must still be considered and excluded. Most importantly, they are going to be negative for PCR and more likely to be serology positive if that is accessible acutely. So you'll have persistent fever, and this is usually reasonably good going fever of more than 38.5. Abdominal pain is probably the key presentation, and they can present with hypotension in a significant majority. Oxygen requirement is less likely. If you do baseline bloods, and I'm only going to talk about bloods which are available throughout the length and the breadth of the country, and I'm not going to talk about sophisticated bloods. So if you do baseline bloods, you will see a high CRP. CRP is a surrogate marker of IL-6. Please do not check IL-6 either in primary COVID or in Missy. It's an expensive test, and it's not as reliable as CRP is, which has got a half-life of 12 to 14 hours. You'll see high D-dimers, and I'll come back to it. It's due to the vascular endothelial activation, and it's not necessarily an indication for anticoagulation. Like in primary COVID, you will see low lymphocyte count, and you will see a raised LDH. And probably the acute respiratory distress syndrome and the COVID-19 associated Missy all form under the umbrella or come under the umbrella of cytokine storm syndromes, which is an inflammatory event, probably either to virus exposure or antigen exposure, or in some cases, chemotherapy. And I think the future, particularly with the huge numbers of Missy cases in India, might enable us to have a better understanding of Kawasaki, which we also think is a super antigen mediated post-infectious event, although we've never identified a single infectious trigger. So if you look at the condition which is most often confused with Kawasaki, which is Missy, which is most often confused with Kawasaki, they have some similarities. Both will have fever, both can present with non-purulent conjunctivitis, both can have myocardial, pericardial involvement, both may have elevated inflammatory markers. But the myocarditis in Missy leads to elevated troponin and BNP if you can measure. But the most important clinical difference is this presentation with acute abdomen, which can mimic, as I mentioned earlier, appendicitis. Cardiac dysfunction at presentation and presenting with warm shock and lymphopenia is a very characteristic feature of Missy, whereas you get leukocytosis in Kawasaki. And the age. So one of the things which intrigues us all, and we can't discriminate between whether this is a socioeconomic variable or whether this is a genetic variable, is what I'm showing in these pictures are multiple series from UK as well as later on in US and in France and in Italy, seem to show that a disproportionate number of those who are of Black or Asian origin getting Missy. Now, we don't know if this is due to socioeconomic variables such as overcrowding or living in multi-generational families, or there is a genetic predisposition to multisystem inflammatory syndrome in those of Indian subcontinent origin, because they seem to be overrepresented even in UK. And this has been shown in France, and in US similarly, it's mainly the Hispanic population which are overrepresented. And again, we can't draw firm conclusions between what is due to socioeconomic variables, but there might be something to do with the genetics of this as well. And I'm going to use the first wave UK experience to illustrate the key clinical features of Missy. So most of these children are older, which is a key variable there, between the ages of 8 to 15. Kawasaki is usually under the age of 5. You see the highlighted red bar showing the disproportionate representation of Afro-Caribbean and Asian children in the first wave with Missy in UK. About 1 in 2 will present with abdominal pain. Quite a few have had laparotomies for appendicitis and then found out that the appendix is normal. About 1 in 5 will present with acute kidney injury. And like in other series, half of them will need inotropic support. And some of them even need ECMO after mechanical ventilation is not appropriate. Or in 2/3 of these patients, intravenous immunoglobulin was used. And I'm going to come back to that. IVIG is expensive. It's in short supply. So we need to look at tailoring therapies which are more appropriate in the Indian subcontinent context. And I'll come to that. And about 2/3 of the patients also got steroids. And most of this was being used without a clear rationale. Because we use IVIG in Kawasaki, let's try it. Because we use IVIG in toxic shock, let's try it. Coronary artery aneurysms, which is a feature of Kawasaki, is thankfully very low. So this condition is more about myocarditis, reduced ejection fraction. And in the first wave, in this series, there was only 1 death. Most of these kids are going to be negative for PCR and are more likely to be antibody positive, clearly demonstrating that this is a post-infectious phenomena and not an infectious phenomena as primary COVID is. Baseline bloods will, like in primary COVID, show a low lymphocyte count, a very high CRP, the mean is 229, and I'll come to how this can be a discriminating variable. The LDH is only mildly elevated, so it's not a very useful investigation. But troponin and pro-BNP, if they are accessible, clearly demonstrate the myocardial injury and can be a good prognostic marker of who's got cardiac involvement. The D dimer due to vascular endothelial activation is usually elevated in the thousands, but it's not necessarily a risk factor for thromboembolism or a requirement for anticoagulation just because the D dimer is in the thousands. So how do you discriminate Kawasaki from PIMS-TS or Missy or from toxic shock? So Missy usually happens in children between 5 and 15. They're more likely to be 8, 9, 10, and 11, whereas Kawasaki with shock and toxic shock tend to be in children under 5. The lymphocyte count is very low in Missy, whereas it's not necessarily low in Kawasaki or in toxic shock. The CRP elevation that you see with Missy is usually over 150, 200, sometimes even 400. The CRP elevation in Kawasaki is usually not as high as it is with Missy. So this is a good pictorial representation of the gamut of manifestations that you see. The ones in the red are the ones you need to watch out for. So persistent fever with acute abdomen, perimyocarditis, mainly myocarditis with reduced ejection fraction, and then a host of other features which can be similar to Kawasaki. We have shown that this picture in the first wave in India is very similar to that in UK, and this is from Kanchi Kamakoti Child's Trust Hospital in Chennai, which I was involved with. And then we've done the British Paediatric Surveillance Unit, which looked at about 268 children who were classed as Missy. And so every pediatrician in UK will fill one of these cards to see if they've seen a child with Missy. And this ran over a period of 3 months between March 15 to June 15 in 2020. And what we did was we identified 3 real patterns, a pattern which was primarily Missy, one which overlapped with Kawasaki, and one which overlapped with toxic shock syndrome. They were about a slight male preponderance, but most of these kids were older. Again, 8 was the mean age. Obesity or a high BMI was a clear risk factor. And this could be explained by probably that the fat cells can, on stimulation with an antigen, produce more IL-6, leading to a cytokine storm. Again, a disproportionate amount of these patients were either Black African, Caribbean, or Black British, or classify themselves as Asian British, clearly showing the complex interplay between genetics and socioeconomic variables. 1 in 2 was admitted to PICU, and 1 in 3 required anecdotes. So these are acutely sick children. But we identified 3 groups really in using a complex statistical tool called latent class analysis. And what we showed is one group of patients present with mild Missy. They're less likely to have hypotension and they may have abdominal pain, but not really acutely unwell. And then a group which is very similar to Kawasaki, a high proportion having conjunctivitis, having Kawasaki-like lips and mucosal features. Again, hypotension isn't a huge variable. But then a group which presents really unwell, acute abdomen, hypotension, and a high requirement for intensive care admission requiring ventilation. 1 in 4 of these will get acute kidney injury, and 1 in 5 will have raised creatinine because of that. So really there is a group which is mild, a group which looks more like Kawasaki, and a group which presents in warm shock, the group which you really need to be worried about. So how do you treat? And let me try and give you some evidence base. We gave IVIG because it looked like Kawasaki, it smelled like Kawasaki, but is that the right drug? You know, when you have got a 50-kilo child and you're giving 100 grams of IVIG, and where most of patients in India pay out of pocket, that's a huge expenditure for a drug which is in short supply as well. What the French did here was use propensity analysis, which again is a complex statistical tool, to show if they can compare those who got IVIG plus methylprednisolone to those who got IVIG alone. And what they showed was if you gave both IVIG and IV methylpred in the severe patients, you did much better. You had a decreased PICU stay and a quicker recovery. But that's not the question we need answering. So this is hot off the press. It's only 48 hours since it's been published. And I was asked to give a press comment on this. And this group, which is called the BAT study, looked at over 600 plus children who had multiple therapies all over the world. And it could be either IVIG plus steroids, or just IVIG, or just steroids. And the key question we want answering is, does steroids alone, because it's cheap, it's relatively safe, can do the same job as IVIG? And what they show here is that the coronary changes are much less in the group which got steroids, albeit the sample size for the steroid group is smaller. Excuse me. So it looks like the myocarditis responds better to steroids alone. There was no difference in the lymphocyte count or the CRP between the 3 groups. So there are no indications that the steroid group was a less severe group, or there is some sort of selection bias. And what I'm showing you here is what happens when you give IVIG plus steroids versus giving IVIG alone. So there's a clear advantage if you give both steroids and IVIG in terms of reduced requirement for respiratory support. They get better quickly, and also the time to stop inotropes is longer with IVIG alone. The time to decrease ventilation is longer with IVIG alone. The IVIG group requires oxygen for longer and remains in a severe state for longer. But then again, the question is, can you give steroids alone and get away? And according to this retrospective analysis, which has got its issues and biases, but nevertheless is the best evidence we have to date, clearly suggests that steroids alone is as effective, if not slightly better, in this retrospective cohort study. And what they're showing is you get to stop the inotropes quicker, you get to come off ventilation quicker. It helps with the myocarditis better, and it enables you to come down on the severity score quicker. And these are some nice graphs that they're showing, that if you compare the patients who got an immunomodulator, be it steroids, IVIG, or some other drug, the reduction in CRP, the red line, is much quicker than the blue line, the group which did not get any immunomodulator. And the same is true for troponin, which is reflecting myocardial damage, and ferritin, which is just an acute phase reactant. And here you're comparing IVIG alone, which is the green line, versus IVIG plus steroids, which is the blue line, and steroids alone, which is the red line. And I would like to point to you that in the group which has myocarditis, and if you take troponin as a marker of myocarditis, steroids alone seems to result in a greater reduction. I'm not recommending you measure troponin regularly, but they've used this as a surrogate marker of the efficacy of steroids. And here they're talking about the time taken to change. And again, for those with cardiac damage, steroids seems to be much better in reducing the markers of cardiac damage. We have shown again in a child in India who did not respond to IVIG and steroids, giving tocilizumab, although this is expensive and in short supply and should be reserved only for very severe patients. So I'm involved in the pediatric recovery trial, which has led to some major advances in adults. And we hope to conclusively answer the question of whether in a randomized control trial, steroids versus IVIG, and we also have a second arm of tocilizumab versus anakinra. We've so far recruited over 270 children. We are collating the data and resolving the data queries. And in the next few weeks, we should be able to publish this. So the key message is there is a new syndrome, which is Missy, which occurs usually 3 to 4 weeks after a community peak of COVID in adults. It can present as an acute abdomen. It will present with high CRP, low lymphocyte count, and a high D dimer. They're usually negative on PCR and more likely to be positive for SARS-CoV-2 serology if you can check it. How would I treat? If they're under 5, I would treat it as Kawasaki with IVIG and aspirin, which they're less likely to be. If they are more than 5, I would go with IV methylprednisolone, probably 10 per kilo. And if they're very ill, then I might consider both IVMP followed by IVIG. In refractory children who are not getting better with IVIG and IV methylpred, you can consider the use of IL-6 blockade, such as tocilizumab. I'm not talking about IL-1 blockade like anakinra because it's not available in India. Make sure you save a serum sample for serology before you give IVIG. And we've just touched on this. So some of the questions which come up, can you use steroids instead of IVIG? And I hope I've shown you some data to suggest you can. IVIG is expensive, it's in short supply, and when people pay out of pocket, it's probably not appropriate. The very fact that we have been doing a randomized controlled trial suggests there's equipoise, and this data, which is hot off the press about 48 hours ago, does suggest that steroids are as effective, if not marginally better. What dose of steroids? If you're mild to moderate, use 1 to 2 per kilo. If you present with hypotension or evidence of myocardial damage, use 10 per kilo for 3 days. In the recovery trial, we use 10 per kilo. There are different mechanisms, and I can address that if you have questions. One of the questions which comes up, should you anticoagulate everybody or selectively? Please do not anticoagulate all children. Only anticoagulate if there is a high BMI, a need for prolonged hospitalization. Otherwise, children mobilize quickly, and D-dimer is not an indication for anticoagulation. You do not need to monitor the D-dimer, do not need to do the IL-6 levels. Clinical indices of improvement is what you need to watch. And if you're going to do any blood tests, then CRP is probably the most useful. I'll stop there and take any questions. Thank you very much.
Thank you so much, Dr. Ramanan. That was fabulous. So it took us through the pathophysiology as well as the management of MIC, and that I think is quite important because we are going to see such cases as we go along. So I think you have pretty much explained it very well. So there might not be questions right up front. But I might ask you just one question. Because there is myocarditis, do you think the troponin or pro-BNP is something that can be used, or is there any data on that? Because most of the emergency rooms will have trop-T, trop-I that they can easily do. So is that something that can be looked into, or that is not required at all?
No, I think if you have access and if affordability is not an issue, the troponin and BNP is a marker of myocarditis or myocardial damage. But I know that Missy is presenting in every nook and corner of India, as there is community prevalence of adult COVID in every nook and corner. So I don't want people to think that absence of getting access to troponin or BNP is going to adversely affect the management. Probably the CRP is more important, the full blood count is more important than any other blood test.
Right. Great. So I think we will, this was definitely helpful. We will go on to some other aspects and come back to the management of MIC as we get more questions. So I would invite Dr. Satish Rao to highlight some of his experiences and what are the respiratory problems that you face with COVID in children.
So COVID in terms of the respiratory illness has been a fairly minor respiratory illness. Even in children who have had complex medical backgrounds, we look after children with quite bad cystic fibrosis, severe asthmas, or oncological problems or transplantation. Even in that group of children, the respiratory aspect of it has been usually very minor respiratory illnesses. And in our experience, majority of our positive results is detected incidentally. And that is what usually happens. Either the child is undergoing surgery or as part of infection control, during admission or during the stay in the hospital, they do have COVID swabs, COVID PCR tests done. And most common presentation is one of an incidental finding. The other common presentation tends to be part of our infection control at this point in time is we also take swabs on the parents, especially if the child is going to stay overnight. And in some instances, parents are positive and that requires isolation. And subsequently, the child might turn up to be positive. So that's number one. So if in UK setting, certainly, and in Western world setting, severe respiratory illness usually is non-COVID. So it is important to bear that in mind, that it is usually other viruses. During the first wave, number of our intensive care admissions were mostly paraflu stroke adenovirus. COVID was an incidental finding, and that played out even in the second wave. There is a paper from Brazil, though. I mean, Brazil published in Lancet a slightly different experience of theirs. Now, again, there are various problems with the methodology of that paper. However, there may be an indication that in some parts of the world, COVID may cause severe respiratory illness. So that is worth bearing in mind. Now, anecdotally, when we have been in touch with various colleagues in India through various sort of WhatsApp groups, there is a pediatric pulmonology group, so on and so forth. It is fair to say that they have seen more severe cases, respiratory failure cases, than probably we have. I mean, we have our ICU admissions, as I've said, have not been COVID as such. COVID has been an incidental finding. So that's, I think, the point number one to bear in mind is if a child is unwell and if it is a respiratory failure, the likely causes are mostly non-COVID rather than COVID. And even if we do find COVID, please bear in mind that it may be a coincidental finding rather than the causative agent. That is worth bearing in mind. And where we have, I mean, UK has had very low mortality. Now, UK ICU admissions, majority have been due to the MISC rather than primary respiratory failures. And the primary respiratory failure where we have lost the odd child, they have had comorbidities, mostly neurological, quite severe neurological comorbidities. In the first wave, we lost, in the UK, a 13-year-old otherwise healthy boy died COVID respiratory illness, but that again is a very rare case. So where we have lost children to the respiratory side of things, as a respiratory failure and not as MISC, it has been in children with severe underlying neurological comorbidity. So I guess that is our experience. Now, in terms of shielding, even in our group of patients, soon after first wave, we de-shielded. Majority of the patients in UK went back, they de-shielded, and after the first wave, in fact, last September, kids went back to school, whether they had transplants, whether they had severe asthmas or rheumatological problems or respiratory issues. So it was really severe immunodeficiency was a group that actually stayed at home and still continue to shield, whereas rest of them de-shielded. That's worth bearing in mind, because one of our anxieties has actually been the effects not of COVID on children, effect of other things on children. That's actually bearing out quite significantly. It is well known across the globe that there has been an increase of about 30-50% in mental health illnesses. We have certainly seen that within our service. We don't get most attendance as well, although last 2 or 3 weeks has changed a bit. We can touch on that a little later about resurgence of respiratory viruses. The predicted 30-50% increase in respiratory viruses over a prolonged winter later this year. If we have time, I'm quite happy to touch on that. But mental health illness related admissions have gone up by 30-50% over the last year. So that has been a major cause of worry.
Right, great. So I think that is very helpful to know that most of the kids, even if they have some respiratory symptoms and you detect COVID, that might just be a co-infection and you need to seek out for other infections. So that is an important point that we need to take home from this discussion. So I would just like you to elaborate on the other respiratory infections that you feel that there's going to be a surge, and why do you think that is?
So the data from the Southern Hemisphere, from Australia and some parts of Africa, seem to suggest that as one of the hypotheses, as kids have not been exposed to the usual run of respiratory viruses because of the lockdown last year, especially the older infants and preschool children, there is definitely an unseasonal increase in the respiratory infections, respiratory viral infections. Over the last 3 to 4 weeks, UK has seen that. All our emergency departments, our numbers of children attending emergency department is similar to what we would have seen in the middle of winter, November, December. Well, it's start of winter, but that's the busiest part of winter in the UK. So our numbers over last 3 weeks have certainly been the winter numbers. Majority of the illnesses, again, we are not finding COVID, although the community prevalence, although the cases are going up a bit, the community prevalence is obviously low at this point in time. But we haven't seen COVID there. It has been mostly respiratory illnesses, paraflus, rhinovirus, paraflus. We are seeing more of it. There are various modeling going on, and none of the modeling is actually accurate. But one of the more likely models is predictions is that there probably is going to be about a 30-50% increase in respiratory viruses this winter, and the winter is probably going to be prolonged as well. So in the UK, we do see a spike in September. That's when children go back from schools, so go back to schools rather from summer holidays. We do see a slight spike in respiratory viruses about 10 days after children go back to school. But our next week is usually sort of November, December. But what is being sort of worked upon, or there is a sense of worry that these respiratory viruses will probably start from about August through to next February. So there is considerable degree of anxiety about that. And the Australian data is that these are not children who are sick. So it is not that they are ending up in critical care units. But they certainly, a fair proportion of them are requiring hospital admissions and hospital attendances. So it is the emergency room and the general pediatrics component of the service that we are worried about starting from August onwards.
Interesting. And just one more question to that. You mentioned rhinovirus and paraflu. But what about influenza? Because that is one thing that has seasonal variation, and every time you have a new virus. So what do you think is going to happen? I'm just asking this because a lot of Indian kids are now running for flu shots. And do you think that is appropriate?
So I suppose I think Professor Azeem probably will be more more qualified to answer that that question than I am. I mean, certainly as a non public health person, as a respiratory guy, I am worried. What will be the interaction between the flu as well as other respiratory viruses? And I think the major problem that we will have this year is, I think in pediatrics we've shown that COVID is incidental finding almost. Whether there has been no indication that from respiratory point of view that has changed with many variants. Certainly with the Kent variant here, there was no change. And with the Indian variants, it seems that from children's clinical manifestation, it hasn't changed much from respiratory point of view. But then the other problem that it actually creates is, just in terms of running organizations. Now, at this point in time, we are, cohorting based on the COVID status of the patients when they come into the clinics or into the hospitals. So, with the numbers that are expected to go up, do we just start ignoring the COVID side of things? I don't know. That is another debate that's coming up. Maybe in terms of the interaction between various viruses, I just wonder if Professor Azeem would like to come in.
Yes, Professor Azeem.
Thank you very much. So I think, as was mentioned, during the winter in the UK and many other countries, rates of flu fell to a very low level. In fact, there were record low levels there this winter in the UK because of school closures, people working from home, lockdown measures. But now that schools have reopened and societies have reopened as well, we're finding rates of flu and other infections are increasing again in the UK and elsewhere. I think one concern which has been alluded to by Dr. Rao is next winter. So this winter we're very fortunate that we didn't have much flu in children or adults, but next winter could be very different. We might have a lot of flu recirculating, and if that's combined with a large outbreak of COVID-19 again, that then places a double burden on the health system in the UK and other countries where that occurs. So I think it's very important we do get vaccination rates up to a high level during the summer from COVID-19, and then the autumn onwards we get vaccination for flu up to a high level as well, because if we face a double jeopardy of both flu and COVID-19, that will really place a lot of pressure on our health systems globally.
Right. So that is helpful. Prof. Majeed, I would like to ask you about vaccination. So I'll just shift gears a little bit. And what do you think about vaccinations for kids? Because we are seeing that most of the kids have a very mild infection. They are not going to the ICUs. They are not getting a lot of problems. Most of the problems are post-inflammatory or post-infectious inflammatory syndromes. So what do you think about vaccinations? Yeah, I would.
So I personally am in favour of vaccination for older children, those 12 and above, and that's the case in some countries. So Canada, Israel, and some other countries have started vaccinating older children. In the UK, there's a bit more reluctance to vaccinate older children because the risk to them probably is quite low from COVID-19, although there are some risks, as we've seen from the presentations, in terms of severe outcomes. So there are mixed views here. So my own personal view will be that it's good to vaccinate older children. It protects them, it protects their parents and grandparents. It helps keep schools open, and it's better for society generally. But I'm aware there are some people who are opposed to vaccinating children in the UK and elsewhere. But I personally would be in favour of that, certainly for older children.
Right. Just there's a question that has come up about the differential diagnosis. So Professor Satish Rao just mentioned, but when a child comes to you, there are two differentials that you think of. One is the when the child presents with URTI or upper respiratory tract infections. The other is a child presenting to the emergency room with Kawasaki's or MIC-like syndrome. So what are the differentials that we should consider? Open to the panel. And how do you differentiate? So I think, yeah, let's think about just the upper respiratory infections and the MIC. How do you differentiate, and what are the differentials that you should consider?
In terms of respiratory illness, COVID unfortunately causes, in majority, in quite a significant proportion, as we have heard, it is asymptomatic. But in others, there is slight, well, it's very difficult to differentiate them from the usual viruses. That's the first point. In younger infants, symptoms are fever, cough, and possibly there is slightly higher rhinorrhea. Whereas in older infants and in in adolescents and young people, the incidence of fever is less, so they tend to have much milder illness. But apart from that, it is very difficult clinically to say what is what. Now we know that the chest X-rays are fairly non-specific. They are not helpful in differentiation. Neither are the inflammatory markers helpful in differentiation. So certainly those are some of the things which are not required. Even in moderate cases, we won't advocate looking for inflammatory markers or chest X-rays from respiratory point of view. CT scan is a definite no-no. CT scan has, in adult world, there is fair degree of validation of CT scan, but the CT in children, even in severe cases, if they have ended up on ventilator, is fairly useless in terms of essentially, from management point of view, CTs are not useful. So I think it is just a very good general pediatric approach, being aware of what are your local pathologies, local infections that are prevalent in your area. And I would probably say in mild to moderate cases, it is mostly your normal infections, if I can use that expression, rather than COVID. Now, I haven't seen a lot of robust data come out from India. I have seen pockets of some centers essentially coming out with certain degree of their own experiences. So therefore, we just need to be mindful whether it's behaving slightly different in India is a question mark. Now the Brazil data says that may be possible, but that is something that we need to keep looking at. Between waves, things are changing a little bit respiratory illnesses wise. In fact, the latest ISRAC study has shown that the second wave respiratory illnesses were in fact milder. On all accounts, it was milder. So they looked at whether it was use of antibiotics, steroids, or oxygen. The use of these interventions in second wave was significantly less than it was in first wave. So certainly from UK experience, from second wave point of view, there was no. I think I can see a question in the chat. Right. From that point of view, there is no evidence. And from the Delta variant point of view, again, there isn't any major worry that respiratory illness in children are behaving differently to the earlier waves. And that's been reassuring.
Right. Great. So yes, over to you, Prof. Ramanan. So again, most of the children, as you see, are not presenting with respiratory illnesses, but with the MICs, and that is where we are losing the children. So how do you approach such a child? You have already mentioned it, but just for some people who might have joined late.
Sure. And just to back up what Dr. Rao said, primary COVID or respiratory COVID is not an issue. So if you have a child presenting with fever, you just deal with them as you would in your setting. In terms of Missy, the presentations we've seen is really threefold, including in the Indian context. You'll have some who will present with fever, but not that unwell, which is fine. You've got a lot of time. What you have to watch out for is the kids who present with acute abdomen, which might land up going to surgeons. So having a heightened awareness, the 3 to 4 weeks after there is a peak in the community of adult COVID, when children get seen in accident emergency or emergency rooms with acute abdomen, the prospect of Missy is also considered. And there are simple ways to discriminate. They'll have a very high fever, extremely high CRP, a low lymphocyte count. So these can help discriminate. The ultrasound abdomen is not usually a good indicator of differentiating from acute appendicitis to the Missy presentation, but a high index of suspicion is required. And the differential diagnosis in a younger child will be Kawasaki. And I think under 5, if you have persistent fever and Kawasaki-like features, you should treat as Kawasaki. And some of the older children, toxic shock syndrome or sepsis as a differential diagnosis. But I think the challenge will come as we get into the dengue season as well, that might be a bit more of a challenge. But there are baseline bloods which are quite different in terms of CRP and lymphocyte count.
Thank you so much. That was very helpful. All the three panelists. Just before we end, just one question. Anything different for the infants and newborns?
No, we've been looking, we have a recovery study open for newborns as well as in infants, and I don't think there's much cause for concern overall. It's been reassuring. There have been 1 or 2 episodes of very young neonates and infants presenting with multi-system inflammatory syndrome, but those are anecdotes. I think in general, there's no need for much panic, no matter what variant. Children get exposed to COVID, but seem to deal with it incredibly well. And that includes neonates and infants, unless they have other comorbidities and so on.
Right. So I think that was a very useful session. We are almost at the end of the session. We have shot over by 5 minutes or so. But I would be I'm grateful to all the 3 panelists for your excellent thoughts, and the research that goes on behind all this takes a lot of effort. And that is very helpful for people like us, because in India, we feel that we are overburdened with so many patients that we hardly get time to sit down and write a paper or analyze the data. At the back of our mind, every physician has seen a lot of cases, so he makes his own inferences. But sometimes those conclusions might not be right. It might just be an impression or a skewed impression. So I think this sort of data, this sort of discussions help a lot. Thank you so much. Over to Deep.
Thank you so much, Dr. Chetan. And what a wonderful presentation and a brilliant discussion, I must say. A quick question, if I may ask, it just reached into our chat box now. Is there a chance that vaccinating children with COVID-19 vaccines would increase the risk of MISC? And could MISC also present as atypical Kawasaki? If anybody would like to take it up, and that would be our last question.
Sure. There's an event called antibody-dependent enhancement, which is sometimes seen with dengue vaccination, which was a major source of concern at the start of COVID vaccines. But reassuringly, that's not been evidenced so far. We have only very small numbers of children on the Oxford AstraZeneca vaccine that have had it as a part of a clinical trial, which our site participated in. But in adults, that's not been an experience. So the ADE, antibody-dependent enhancement, happens when you have had a previous exposure to the virus and then you get the vaccine, and whether there's an exaggerated immune response. But I think the risk of that is very low based on huge numbers of people vaccinated already, although that data is from adults. And I think the Kawasaki question, if they're under 5 and they present with persistent fever and Kawasaki-like features, treat them as Kawasaki. If they are more than 5, in the current context, when you have a lot of COVID, then think of this. And if there's more Kawasaki-like features, perhaps if access to IVIG isn't a restriction, then IVIG is a better drug. But even in Kawasaki, we are starting to do trials to show that steroids might be as effective as IVIG.
Brilliant. Thank you so much.
Great. Yes, Dr. Chetan.
Yes, Deep. So closing remarks, very useful discussion. Important to understand that children might present with very mild disease, so need not worry about any child who is having a runny nose. Influenza this season we feel will not be as bad, but we have to be prepared for the next season. But again, things might change as we go along, and we will depend on local epidemiological data to navigate through this pandemic on the influenza front. Of course, other respiratory viruses will make their mark as we go along, and we have to be aware of that. But it is going to be mild. No, there is no need for panic. No need for panic about vaccinations. Children have gone to school without having problems. So people who are de-shielded, children who are de-shielded did not have a problem. Just that they should not spread the virus to elderly people in the house. So if you are elderly, are vaccinated, you are like a good chance of allowing your kids to go to school. So that was important. And vaccines should not be a concern. So I think that was very important. MIC rare, but steroids can be used. No need to worry about IVIG. We should not create a false panic and shortage of IVIG in the country. So I think those are take-home points, which I think will go a long way. Thank you so much, all of you.
Great. Thank you so much, Dr. Chetan. On behalf of our viewers, participants, the organizing team, and from British High Commission, I would like to extend our sincere gratitude to our speaker and moderator. Thank you so much for joining here today and spend your precious time with us. We hope to see you in future and wish you all the very best. Thank you so much. Before we move ahead, I would request Dr. Vinisha to just show the disclaimer slide. Thank you. These knowledge exchange sessions contain general information about medical condition and treatments. The information is not formal clinical advice and should not be treated as such. The medical information provided without any representation or warranties expressed or implied. We, the NHS, make no representations or warranties in relation to the clinical information offered. You must not rely solely on the knowledge exchange session as an alternative. If you have any specific question about any medical matter, you should consult other professional healthcare colleagues. It is important to understand that NHS healthcare professionals are providing their NHS experiences and their knowledge on the management of COVID-19. The duty of patient care will remain the responsibility of colleagues in India. NHS organization, bodies, or workforce will not take any direct or indirect responsibility of patients who are not under their direct care or supervision. Thank you so much, Vinisha. Well, with that, I would like to thank you once again for a wonderful session to all of you and joining us. I think with that, I would like to call it a day. And thank you so much, everyone, and have a wonderful evening, afternoon. Take care and bye-bye.
Thank you.